Thank you for joining for the Lymphoid Disorders lecture of the Hematology and Oncology unit for the General Medicine course. Please be sure you have your study guide so you can complete that as you go through this lecture. The learning objectives for this lecture are listed below. Please do make sure you are looking through these so you're ready for the exam. Before we talk about lymphoid disorders, it's first important to discuss hematopoietic stem cells. In our previous lecture where we were discussing myeloid disorders, we were talking about the myeloid cell lines, but this time we'll be talking about the lymphoid cell lines. So you have your hematopoietic stem cell, which will develop into your lymphoid progenitor. So we'll be talking about this grouping of cells here. Specifically for these lectures, we're going to be focusing on the lymphocytes, and you'll also see, of course, that our B lymphocytes will develop into our plasma cells. So when we talk about the plasma cell disorders, realize that these are also still B lymphocyte disorders. So here's another view of the lymphoid disorders, not looking from hematopoietic stem cell point of view, but just hematologic malignancies in general. And the area that we'll be discussing today are the lymphoid disorders, and these will be divided into two big areas: the acute lymphoid leukemia and then all the chronic lymphoid disorders. So just a reminder from the previous lecture about leukemia. Leukemias are malignancies of the progenitor cells, so these can be myeloid or lymphoid cell lines, so either one of those, and the name will tell you which line it's coming from. And remember that the progenitor cells are the blasts or the immature cells, and when you have a leukemia, they start accumulating in the bone marrow. Eventually the bone marrow fills up with these immature blasts, and you start having them spill into the peripheral blood, and eventually as they start filling the peripheral blood as well, you'll start having them accumulate in other tissues of the body. Remember that the blast cells are non-functional cells, and because they eventually start taking up the bone marrow, they can lead to pancytopenias because you start losing your normal cells that should be there. Again, another slide from the previous lecture, but just a review of the signs and symptoms of leukemia is the big ones being fevers, chills, and night sweats, weakness or fatigue, infections related to the bone marrow being overtaken by the bad blast cells and you're losing some of your good original cells. Weight loss can be a big symptom of this. The lymphadenopathy can also develop, as well as hepatosplenomegaly, because of the blast cells starting to take over the other organs. As they start moving from the bone marrow, they start taking over the blood, and then eventually they start depositing in the other organs. Petechiae and purpura epistaxis are related to, again, some of those cells, the bad cells, the blast cells, start taking over the bone marrow. We lose some of our good cells, so we have problems with the development of platelets as well. And bone tenderness or pain develops because as those blast cells start coming into the marrow and taking over the marrow, there can be pain that develops as a result as well. So the first leukemia we'll talk about for this lecture will be the acute lymphoblastic leukemia, also known as ALL. ALL is a leukemia of lymphoid origin, specifically the B and T cells, and what happens is you have the immature or blast cells for the B or T cells that start proliferating, and they eventually take over the healthy bone marrow. It's important for ALL to remember that most acute leukemias in children, about 80%, will be in ALL, especially with the highest incidence between the ages of 3 to 7. So if you have an exam question or a case study that has a young child who has the picture for leukemia, specifically an acute leukemia, you should be thinking first and foremost that it's ALL. Also to note, in adults who have acute leukemias, it only accounts for about 20% in adults. So it's helpful because the 80 and 20 match up, even though they're not necessarily related. The treatment for ALL is based on the patient's age and several different risk factors. The typical treatment will use a combination chemotherapy, and this usually involves daunorubicin, vincristine, prednisone, and asparaginase. And remission with this treatment is in about 90% of patients. If the patient does have a Philadelphia chromosome for ALL, which is not typical, but is a possibly bad indicator or poor prognostic indicator in these cases, it is helpful to add to that combination the dasatinib, which is a tyrosine kinase inhibitor, and it will help somewhat for these patients. If the patient is above the age of 60, dasatinib plus prednisone is also used. And if you have a chronic remission and you need to do an induction phase for these patients, it's very important to make sure that there is CNS prophylaxis done. And what this involves is intrathecal and or intracranial chemotherapy. So the chemotherapy is put right into the spine or into the cranial region, and that is to help prevent any other issues with meningeal leukemias. They may also have some irradiation done at that point as well, and some other treatments that might be done. So again, possibly some chemotherapies for induction or possibly stem cell transplants. Prognostic indicators for ALL. It is important to look at different prognostics for ALL to decide and dictate the treatment. Some of the good prognostic indicators are no adverse cytogenetics, so no bad gene abnormalities. The ones that I want you to remember for the good ones for ALL are patients who are younger than 30 years of age is a very good prognosis. And if they have a white blood cell count less than 3,000 at their presentation, that is also a good prognostic. Another prognostic indicator that is helpful is if patients are doing about 4 weeks or so of chemotherapy and they've reached complete remission by that point, that is a very good prognosis. There is no specific indicators for intermediate prognostics. It's kind of finding the balance of the good and the poor, but there are some poor indicators that I wanted to discuss. So some of the adverse cytogenetics would be especially this translocation of 9 and 22, which is again that Philadelphia chromosome. And as you remember in our previous lecture, we talked about if you have the Philadelphia chromosome in ALL or AML, both of those are considered a poor prognostic indicator. As well, if patients are older than the age of 60, then they have a much poorer prognosis. So that one I want you to remember. And finally, also remember that if they have a high white blood cell count that's higher than 100,000 at presentation, that is a concern for a poor prognosis. Also, patients who do not reach remission within that 4-week period after chemotherapy started also have a poorer prognosis. Next, we'll discuss chronic lymphocytic leukemia, or CLL. Chronic lymphocytic leukemia, or CLL, is also a clonal malignancy of lymphocytes. So this can be both B cells or T cells. And this is typically seen in older adults, especially over the age of 70. On diagnosis, you will of course see the increased circulating lymphocytes. And another important word to know for CLL would be the smudge cells which show up on peripheral smear. And basically these smudge cells are lymphocytes, but they're extremely fragile. And so what ends up happening, as you can see a couple examples here, you have these cells that are kind of being broken up or smudged on the slide. You also will see with CLL that their lymphocytes start getting into the lymph nodes as well. So it's a characteristic for this that's good to make sure you remember. The staging for CLL is done by the Ray and Binet systems, and this is not a slide that you have to memorize. It's just there more for your information. It's helpful to remember that there is staging that is done for this type of leukemia as well, and it's helpful to know that the staging is based off of some of it's the lymphadenopathy, if there's any spleen or liver involvement, looking at hemoglobin and then platelets. And again, you can see some of the similarities. It still looks at hemoglobin and platelets in the Binet staging, but it doesn't necessarily look at these other two prognosticators here, the lymphadenopathy or the hepatosplenomegaly. The treatment of CLL is based off the Ray stages, as you saw in the previous slide. And you can see below, stage 0 would require no treatment. These patients are monitored. Of course, if these patients progress into some of the other stages, the intermediate stages, the higher stages, they do require treatment at those times. And typically at stage 0, the median survival is greater than 10 years. If a patient is in the intermediate stages, so this is specifically stage 1 and stage 2, most of them will receive some therapy. and if they're in a higher stage, they will most definitely receive therapy, so stage 3 and 4. And the therapies are listed on the other side of the slide, so you can see chemotherapy is the principal treatment. The drugs involved would be fludarabine plus some rituximab, as well as possibly cyclophosphamide. Another option would be chlorambucil. If they have refractory CLL and they don't respond to the first sets of chemotherapy, there are some other possible treatments. Alemtuzumab is a possibility, and also stem cell transplantation is a possibility, but do remember that the older the patient is, the less likely they're going to do well with transplants with stem cells. Allogenic stem cell transplants are potentially curative and are recommended, because if you do an autologous stem cell transplant, you run the risk of still having contaminants in the patient's own stem cells that are harvested. But again, remember that there is a lot of mortality related to this, especially as patients get older. Now we'll discuss lymphomas. Lymphomas are a hematologic malignancy of the lymphoid tissues, and this involves especially the lymphocytes, but it's usually characterized as B cells, T cells, and sometimes NK cells. Lymphomas are named lymphomas because the site of the disease is the lymph nodes. However, lymphomas can also invade other lymphoid tissues. Those would include things such as the liver, the spleen, the Peyer's patches of the intestines, portions of the skin, as well as eventually invading the bone marrow. Lymphomas are typically divided into Hodgkin's and non-Hodgkin's lymphomas. About 85% of non-Hodgkin's lymphomas are of B-cell origin, and Hodgkin lymphomas are all of B-cell origin. Risk factors for lymphomas. There are many risk factors for lymphomas, but one of the most important ones to remember is viral infections, specifically the Epstein-Barr virus. And the Epstein-Barr virus is especially implicated in Hodgkin's lymphomas. Bacterial infections could be responsible for lymphomas as well, especially H. pylori, which is related to gastric-associated lymphomas, also called gout. We'll discuss that a little bit later. There can be different immune issues that could lead to lymphomas. There are some congenital syndromes as well. Lymphomas could be acquired from other treatments such as stem cell transplants. It could be related to aging, autoimmune, and also again acquired from infections like HIV. And also exposures to things such as herbicides and pesticides can put people at risk for lymphoma. The diagnosis of lymphoma is ultimately made by a lymph node biopsy, and the preference for this biopsy would be the excisional biopsy. This is the gold standard method for biopsy. It is possible to complete a fine needle aspiration, also called an FNA, and this procedure is less invasive, and it may be necessary if the node is in a place that's not easily excised. It could also be because the patient is not able to tolerate a surgery, but could have a needle aspiration, which doesn't require the same level of anesthesia to have this done. It also could be related to the surgeon's preference, but ultimately, excisional biopsy of a lymph node is preferred, and this is because it gives you a more accurate diagnosis. Once you have that lymph node tissue, you can send that for pathology to run the testing for looking at Reed-Sternberg cells. If you do have those Reed-Sternberg cells present, you would diagnose with a Hodgkin's lymphoma. And of course, if there's no Reed-Sternberg cells, then it is a non-Hodgkin's lymphoma. Those samples will also be sent for flow cytometry and cytogenetics to get further prognostics to decide on the patient's treatment. Non-Hodgkin's lymphoma. Most non-Hodgkin's lymphomas will present with a painless lymphadenopathy, and these are typically seen in the cervical, axillary, or groin regions. Patients may also complain of fatigue or rashes, and about half of patients will also have B symptoms, and these are constitutional symptoms which can be fever, night sweats, and or weight loss, and this weight loss would be greater than 10% of the patient's body weight over less than a 6-month period. Non-Hodgkin's lymphomas are also put into a grading system. You can have indolent lymphomas, intermediate grade lymphomas, and high grade lymphomas. The indolent lymphomas, with indolent meaning slow growing, painless, or not problematic, typically have that painless lymphadenopathy, whether it be one isolated lymph node or multiple lymph nodes. In the indolent lymphomas, you will see well-differentiated cells, meaning they are very close to normal cells. Typically in this grading, patients have few symptoms, and often in these cases it is less likely to see these patients present early. They may present later once they move up to other grades. And these patients will, however, progress slowly. An example of one of the indolent lymphomas would be a follicular lymphoma, which is the most common type of indolent non-Hodgkin's lymphoma. Intermediate or high-grade lymphomas will also present with lymphadenopathy. Often it is painless. However, as the patient moves to higher grades, they will have more lymphadenopathy and larger lymphadenopathy, and they are more likely to have pain because of the lymph nodes that are enlarged, pushing on underlying structures. In these grades, you can have poorly differentiated or very undifferentiated cells, meaning that they are very abnormal cells compared to the normal cell that they should be. You're more likely to see the B symptoms in these patients, so again, those fevers, night sweats, and weight loss, and patients in the intermediate and high-grade lymphomas tend to progress more quickly. An example of an intermediate grade lymphoma is a diffuse large B-cell lymphoma, which is the most common type of lymphoma. A high-grade lymphoma would be something like the Burkitt's lymphoma, which is very rare but very aggressive. Also, another rare and usually higher grade lymphoma is the T-cell lymphoma, as they're often presenting with a cutaneous manifestation, which we'll talk about in a little bit. When staging non-Hodgkin's lymphoma, it's important to take a very good history and physical. Also be sure that you are documenting any of the B symptoms. Laboratory evaluation will include a CBC and most likely a peripheral smear as well. Liver function testing, uric acid, and calcium testing are also recommended. Patients should have a chest x-ray as well as CT scans of the abdomen, pelvis, and the chest as well to look for any other node involvement. Patients also will receive a bone marrow biopsy and possibly a lumbar puncture depending on the type of non-Hodgkin's lymphoma they are diagnosed with. Other scans can be done, especially things like PET scans, to look for cancer involvement in other areas of the body. But ultimately, please remember that the lymph node biopsy is your most important test for getting the correct diagnosis. The staging for the lymphomas are listed below. Let's go through a couple of these right now. Stage 1 will involve a single group of lymph nodes, and notice it says a group, meaning you could have a cervical group, you could have a supraclavicular group, but it's a group of lymph nodes, not just a single node. Or possibly you could have a lymphoid structure. So this could be the spleen or other lymph organs involved. In stage 2, you'll have 2 or more lymph node groups involved, but very importantly, they are on the same side of the diaphragm. And we'll look at some images on the next slide, and that will make a little more sense. Stage 3 will be the involvement of lymph node groups on both sides of the diaphragm. And that means obviously you're going to have at least 2 groups involved. So you're going to be past that stage 2, but because you have one group on one side of the diaphragm and one group on the other side of the diaphragm, that would put you in stage 3. Now, if you had 2 groups on the one side of the diaphragm and one group on the other, that still puts you into stage 3. Stage 4 will also involve some extranodal sites, and we'll get the designation of E. So those would be common places such as the spleen, liver, or the bone marrow also having involvements. Finally, you'll have the A and B symptoms noted. So if there are a presence of B symptoms, you'll give it a B. If there's no B symptoms reported by the patient, it will receive an A. Also, you'll see this X designation for bulky disease, meaning that they have pretty big lymph nodes involved. Usually it's greater than 10 centimeters, and of course you could also see some changes in the mediastinum where you have a node, and that would help with that diagnosis as well. Here's the photographic representations of the lymphoma staging. So for stage 1, you will see that this patient has just one group of lymph nodes involved. That would qualify for stage 1. In stage 2, there are 2 or more groups of lymph nodes involved, but they are all on one side of the diaphragm. So here's the diaphragm here, and here are my 2 groups that are involved. So for this case, if you wanted to, for example, take out these groups, they're no longer there, and I had lymph node involvement on both sides of the groin, for example, I would have one here, they're both on the same side of the diaphragm. This would still qualify as stage 2. In stage 3 disease, you have groups on both sides of the diaphragm. And in stage 4, not only are there multiple groups involved, but we also have organ involvement or other lymphoid involvement. So that would be the spleen, the liver, and you can see here they also have bone marrow involvement in this case. Just to review the lymphoma B symptoms, again, fevers, and a lot of times for these fevers, you will see them waxing and waning, and these can sometimes be the reason for a fever of unknown origin. So you have a patient who comes in, they're having fevers, and we're not able to find a cause. There's no other infection that's apparent. So fever of unknown origin, you should always have a lymphoma on your differential diagnosis. Sometimes these waxing and waning fevers, you'll see them referred to as a Pell-Ebstein fever. So they have periods of fever as long as afebrile periods. For the night sweats, these are considered drenching night sweats, meaning that the patient has to wake up and change their night clothing or their bed linens because of the amount of sweating. And again, that unintentional weight loss greater than 10% of weight, and this is over less than a 6-month period. Remember, if the B symptoms are present, then you would give the staging a B after the stage, and if they're absent, the staging will receive an A. One of the most important medications for treating non-Hodgkin's lymphoma is rituximab. Rituximab is a monoclonal antibody which is directed against CD20. So this is an anti-CD20 medication, and CD20 is seen on B lymphocytes. So any of your B lymphomas, which are about 85% of non-Hodgkin lymphomas, are going to be treated with this medication. They also are put into combo chemotherapy, so you can see our rituximab is here for the combos. That's where the R comes from for both of these. And then the other chemotherapeutics are put in there. So you often heard these referred to as an R-CHOP chemo or an R-CVP chemo. Now let's discuss some of the treatments for specific types of lymphoma. First, we'll talk about follicular lymphoma, which again is one of those indolent lymphomas. Remember that it often does not require treatment. It's indolent, it's early, and is progressing slowly, so it won't need treatment till later. However, if the patient has some specific symptoms, then they may be treated. And these are listed below. They would include progression of their disease or bulky disease, and that would mean, in this case, greater than a 5-centimeter mass. If they have any other organ compromise, then that would be an indication for treating them. If these patients do have the B symptoms, they should be treated as a higher staging. Also, if they have any other symptoms of extranodal involvement, meaning that other organs are involved with some of the infiltration of the abnormal cells, so these would be pleural effusions or cytopenias due to bone marrow involvement or involvement of the spleen, then they should also be treated, and they will again receive this rituximab with some sort of combo therapy. So that would be either our CHOP therapy or the CVP therapy. Diffuse large B-cell lymphoma is again an intermediate grade lymphoma. It is typically treated with the rituximab treatment because again it is a B-cell lymphoma, and it is going to also have the combination therapy, so that's going to be either your CHOP or your CVP treatment with chemotherapy. It is important to remember that if these patients do relapse, that they can be treated with a stem cell transplant, but often this is considered a very poor prognosis for these patients. For the treatment of Burkitt cell lymphoma or Burkitt lymphoma, Remember, this is a very aggressive, very high-grade lymphoma. It's commonly related to HIV infections and is especially endemic to East Africa, so it's very common there. And this is a type of lymphoma that is pretty responsive to the R-CHOP therapy for chemotherapy. But these patients are also going to need CNS prophylaxis, so they're also going to need intrathecal and intracranial treatments of the chemotherapeutic. T-cell lymphoma. So remember that most non-Hodgkin's lymphomas are going to be B-cell lymphomas, about 85%. The rest of them will be T-cell lymphomas, and these are very, very aggressive lymphomas. They do not respond well to chemotherapy, and of course, because they're T-cell, they will not have a response to rituximab, which is against the CD20, which is on the B-cell. Typically, these are divided into the type of mucosal associated lymphomas, and the most common ones will be cutaneous T-cell lymphoma, which you can see here in a photo. So you can see this patient presents with erythroderma, which is deposits of the T cells into the skin. So this is a SALT, a skin-associated lymphoma. You can have gastric lymphomas, so the Gault lymphomas, which patients need to be treated for H. pylori. And you can also have the enteropathy-associated T lymphomas, and these involve infiltration of the Peyer's patches of the small intestine. Hodgkin's lymphoma, or Hodgkin's disease. Hodgkin's lymphoma has a bimodal age distribution, meaning that there's peaks in two different age groups. The first age group is 20 to 30 years of age, and the second age group is patients over the age of 50. Like non-Hodgkin's lymphoma, patients with Hodgkin's lymphoma also present with a painless lymphadenopathy. As well, they may present with the B symptoms of fever, night sweats, and/or weight loss. Other clinical features that you can see in Hodgkin's lymphoma would be unexplained itching, cerebellar degradation, or immune hemolytic anemia. And again, like non-Hodgkin's lymphoma, patients with Hodgkin's lymphoma are ultimately diagnosed by a lymph node biopsy. Most importantly, they will possess the Reed-Sternberg cell, which you can see here, this cell that is indicated on the slide here. The studies for the staging of Hodgkin's lymphoma are the same as non-Hodgkin's lymphoma. Again, a good history and physical, documentation of any B symptoms, laboratory testing, CBC, probably a peripheral smear as well, liver function testing, as well as uric acid and calcium testing, getting your imaging of your chest through radiographs, as well as the abdomen and pelvis through CT, a bone marrow biopsy, and PET scanning. But ultimately, remember that that lymph node biopsy is the most important test you will need to get. The staging for Hodgkin's lymphoma is the same as non-Hodgkin's lymphoma, so just be sure that you are familiar with the staging for both of these and realize that they are the same. Again, here's the imaging of the staging in photographic representation. And again, the B symptoms will be used in that grading as well. There are some important considerations for the staging of Hodgkin's lymphoma. It is more common to see that patients with Hodgkin's lymphoma have a tendency to have a single lymph node group that starts at their disease, and then it spreads in a very typical pattern to the next group. So it's very important to get the correct staging because it has a very big influence on the treatment of Hodgkin lymphoma patients, more so than you would see with non-Hodgkin's lymphoma. Most Hodgkin's lymphoma patients do not have the B cell markers present, so like CD20 as we saw in some of the other cases. Instead, they have other markers such as CD15, which is a myeloid cell line adhesion molecule, CD30, which is a TNF-alpha receptor, and CD45, which is a leukocyte antigen. There is one variant of Hodgkin's lymphoma that does have a CD20 positive variation. It's also important to make sure you look at Epstein-Barr virus and its implications in non-Hodgkin's lymphoma. And you often see that they're Epstein-Barr virus positive. There are several combination chemotherapies that can be used in the treatment of Hodgkin's lymphoma. The gold standard for these chemotherapy combinations is the ABVD, which is adriamycin, bleomycin, vinblastine, and dacarbazine. There are some other options such as escalated BEACOPP, or Stanford V. You can see here that stage 1 or stage 2 disease will be treated with ABVD, the gold standard treatment, and the presence of the B symptoms will dictate whether or not the patient has radiation. So the important things to remember for this section is either way they're going to get the ABVD, but know that if the B symptoms are present, that radiation will be given as well. If you have a patient in stage 3 or 4, or a patient with stage 2 that has very bulky disease, meaning very large infiltration of the lymph nodes, they will either receive the ABVD or the escalated BEACOPP plus or minus radiation. So they may have radiation, they may not. Or there's the possibility that they could receive the Stanford V, but the Stanford V definitely needs that radiation. So make sure you can distinguish that they can get any of these 3 treatments for stage 3 or 4, but the only one that requires the radiation is this Stanford V. The prognosis of Hodgkin's lymphoma depends on the staging. Stages 1 and 2A will have approximately a 10-year survival greater than 90%. Stage 3B or stage 4 patients will have a 10-year survival of about 50 to 60%. And the patients in between stages, so stage 1 and 2B, as well as 3A, will have a 10-year survival between that 60 to 90%. If patients have recurrent disease, they are often treated with a high-dose chemotherapy and may also have stem cell transplantation, about 35 to 50% chance of cure with that if the disease is also responsive to the chemotherapy. Patients who have a poor prognosis in Hodgkin's lymphoma include older patients, patients with bulky disease. Remember, that's again those very big, greater than 10 centimeter lymph nodes. And if they have lymphocyte depletion or other mixed cellular types of Hodgkin's lymphoma, they can also have a poor prognosis. Plasma cell disorders. Plasma cell disorders are divided into multiple myeloma and Waldenström's macroglobulinemia, which is also called lymphoplasmacytic lymphoma. Multiple myeloma. Multiple myeloma is a hematologic malignancy of the plasma cells. Plasma cells are the mature form of a B cell, and remember that these are cells that make a single antibody. In multiple myeloma, there is a defect that occurs in these plasma cells, which causes them to let off fragments of immunoglobulin. Immunoglobulin is normally consisting of 2 heavy chains and 2 light chains, and in this case, there are portions of the light chain that's being sent out into the system. This is also referred to as M proteins. The major symptoms at diagnosis for patients with multiple myeloma are bone pain, fatigue, weight loss, and paresthesias. Some of the clinical features seen in multiple myeloma include anemia, which is often normocytic and normochromic. The anemia is caused by the replacement of the healthy marrow with abnormal plasma cells. As these plasma cells increase, the abnormal plasma cells will start invading the bone marrow and taking up the space of the other progenitor cells. You will see multiple monoclonal or M proteins in patients. Also, you will have increases in plasma cells in the bone marrow, and remember these are abnormal plasma cells, so they start invading the marrow as well. One of the other symptoms that you will see in patients with multiple myeloma are lytic bone lesions, which are seen on radiographs. The lytic lesions are due to abnormal plasma cells that start crowding out the good cells in the bone marrow. This also causes an increase in osteoclast activity, and that will lead to lesions because there's resorption of the bone as a result of this. So you will see pathologic fractures in these patients. As well, because of the bone breakdown, there can be hypercalcemia. Patients with multiple myeloma will also have renal failure, and that is because the circulating M proteins begin to deposit in the kidneys and become nephrotoxic to the kidney. In this case, you'll see an elevation in the serum creatinine. Patients with multiple myeloma also are at an increased risk for infection. This is because there's a decrease in the humoral immunity, which is due to the loss of the normal plasma cells. The workup for a patient with multiple myeloma starts with a good history and physical exam. Blood workup for this patient will include a CBC as well as a peripheral smear. And on the peripheral smear, you may see Rouleau RBCs, and this is a stacking of the red blood cells, which is due to proteins in the blood. We'll talk about that a little bit more with the next syndrome we'll discuss. It's also important to get a BUN and creatinine, as well as electrolytes, calcium, albumin, and LDH. One test that is helpful is a quantitative immunoglobulin and light chain assay to look at some of the changes in the amount of immunoglobulin in the blood. And the most important test would be a serum protein electrophoresis, specifically looking for M spikes, which are as a result of the increased M proteins related to the increased light chains in the blood. You'll see here on this image here that the electrophoresis has that M spike that has occurred. There's also some testing for the urine, and the urine will show these what is called Bence-Jones proteins, and these are again related to the M proteins or the M spikes. You can do an electrophoresis of the urine as well, which will show the M spikes. And the other important test to get is a skeletal survey, and this is a series of radiographs or x-rays which will show the lytic lesions. It is also important to have a bone marrow biopsy so you can run testing for cytogenetics. There are 3 criteria for the diagnostic criteria of multiple myeloma, and this would include the presence of a serum or urine monoclonal protein. So again, testing that on the electrophoresis is that best way to obtain that. The presence of a clonal plasma cell in the bone marrow, so you will need that bone marrow biopsy to get that diagnosis, and this needs to be more than 10%. You also could have the presence of a plasmacytoma that could take place with this criteria, and a plasmacytoma is either a bone or a soft tissue mass of abnormal monoclonal plasma cells. The third criteria is the presence of end organ damage that is related to some sort of plasma cell abnormality, and this is done by the CRAB acronym, and that will be C, which is for hypercalcemia, R, which is for the renal failure, A, which is anemia, and B, which is those bone lesions, which are considered lytic lesions. So lytic bone lesions. And you can see here on the radiograph here, there are lots of different lytic lesions of the skull in this patient. The diagnostic criteria for atypical myelomas. I like to think of the atypical myelomas as the syndromes kind of leading up to multiple myeloma. These will include smoldering multiple myeloma, or SMM, and monoclonal gammopathy of undetermined significance, or MUGUS. For smoldering multiple myeloma, I kind of think of this as the syndrome that has the testing that is positive for multiple myeloma, but it doesn't meet the last requirement. So they'll have the serum monoclonal proteins, and those will be greater than or equal to the 3 grams per deciliter. As well, they will have the plasma cell issues in the bone marrow greater than 10% or equal to 10%, but they do not have those end organ damage issues due to the plasma cells. So that basically is saying that they don't have that CRAB acronym that we talked about. So they do not have hypercalcemia, they do not have renal failure, they do not have anemia, and they do not have any lytic bone lesions. In the case of monoclonal gammopathy of undetermined significance, they will have serum monoclonal proteins, but they're less than the required 3 grams per deciliter. They do have plasma cells in their bone marrow, but they're less than the 10% that is required, and again, they do not have those end organ damage issues. Treatment of myeloma. Chemotherapy is currently the mainstay of treatment for patients with multiple myeloma, and these can include any of these 3 types of treatments or possibly them in combination. Dexamethasone would be one option. The other option would be either lenalidomide or pomalidomide, and another option would be bortezomib or carfilzomib. Patients with myeloma may also be treated with radiotherapy, and this is for their bone pain. It's a palliative treatment. It could also be used for getting rid of a tumor that's at the site of a fracture. If you have a patient with MUGUS or SMM, they will be observed. However, if they do progress to multiple myeloma, they will require treatment. Some other treatment options include managing the hypercalcemia that is seen due to the renal issues, as well as the bone breakdown. Also, vertebral collapse should be addressed with either vertebroplasty or kyphoplasty, or possibly using bisphosphonates to try and reduce the pathologic fractures and to also try and treat some of the hypercalcemia issues. Typical survival for patients when they've progressed to the point of myeloma, which is at the level of multiple myeloma, will be approximately 5 years. And stem cell transplant is being considered for patients, but it's still considered experimental. Waldenström's macroglobulinemia, also known as lymphoplasmacytic lymphoma. Lymphoplasmacytic lymphoma is an infiltrative malignancy of the bone marrow with abnormal plasma cells called lymphoplasmacytic lymphocytes. These cells will cause an abnormally high secretion of IgM. Also, the abnormal cells, the lymphoplasmacytic cells, will begin to invade the marrow, the lymph nodes, and the spleen as the disease progresses. This disorder has an insidious onset, meaning that it comes on slowly and is typically seen in patients in the 60s to 70s. Typically, literature in the past has used the name Waldenström's macroglobulinemia, which is an eponym for this disorder. However, many texts have been switching to the lymphoplasmacytic lymphoma name, and many board exams have now been following that trend. So it is important to know both names, Waldenström's macroglobulinemia and lymphoplasmacytic lymphoma, because at this point not all exams have converted over to the new accepted name. Plasma cell infiltration is one of the major clinical features of lymphoplasmacytic lymphoma. Plasma cells will start to invade the bone marrow and will lead to problems such as anemia and thrombocytopenias due to decreased production of normal cells due to the infiltrate. You can also have infiltration of the plasma cells into the lymph nodes, causing lymphadenopathy, as well as the spleen, leading to splenomegaly. In patients with lymphoplasmacytic lymphoma, there is also hyperviscosity, which can cause visual and hearing disturbances, mucosal bleeding, possibly CHF, and altered consciousness in these patients. The hyperviscosity is related to the elevation in the immunoglobulins, and in the case of lymphoplasmacytic lymphoma, this is specifically immunoglobulin M or IgM. Patients also may present with peripheral neuropathy in lymphoplasmacytic lymphoma, and at this time it is of unknown etiology. To differentiate lymphoplasmacytic lymphoma from multiple myeloma, it's important to realize that there are no lytic bone lesions and there's not renal damage associated with this disease. The laboratory diagnosis of lymphoplasmacytic lymphoma will first involve a CBC and peripheral smear. These tests will show an anemia and possibly a thrombocytopenia. The other thing you will be looking for specifically on the peripheral smear is for red blood cells to be in rouleau formation. The word rouleau refers to cylindrical stacking of coins, which describes the peripheral smear's red blood cells. You can see here are some nice examples of red blood cells in rouleau formation, and this occurs because of increases in plasma proteins. In the case of lymphoplasmacytic lymphoma, this is due to an IgM protein. You could also see rouleau formation in multiple myeloma, which is due to IgA. It is also possible to see rouleau formation occur due to other increases in plasma proteins, which are commonly seen with things such as infections, inflammation, or connective tissue disorders. And the peripheral smear may also show some of the plasmacytic lymphocytes in the peripheral blood. A bone marrow biopsy for a patient with lymphoplasmacytic lymphoma will show inflammation of these abnormal plasmacytic lymphocytes. And remember that the radiographs for the patient are going to be normal. There will not be lytic lesions like you see in multiple myeloma. There is no standard treatment for lymphoplasmacytic lymphoma. Patients with hyperviscosity issues may require emergent plasmapheresis. There are some chemotherapeutic options for lymphoplasmacytic lymphoma, including rituximab, fludarabine, and bortezomib, with the most likely to be used being rituximab, which is an anti-CD20 medication, which anti-CD20 will work against B cells. Remember that a plasma cell is a type of B cell, so this tends to be the most promising treatment for patients. Some patients will also qualify for hematopoietic stem cell transplant, and the survival can be a little lower for these patients with a median survival of 5 years and 10% at 15 years, and this is related to some of the other complications of this disease. The most concerning issue seen in patients with lymphoplasmacytic lymphoma is hyperviscosity syndrome, which is an increase in the serum viscosity. This is due to increase of circulating plasma proteins, and in this case it's specifically IgM. Hyperviscosity syndrome is seen in about 10 to 30% of patients with lymphoplasmacytic lymphoma. You could also see hyperviscosity syndrome in patients with multiple myeloma, and in this case it's due to circulating levels of immunoglobulin A. The symptoms of hyperviscosity syndrome include fatigue, headaches, blurred vision, mucosal bleeding, mental status changes, coma, and transient paresis. Patients with hyperviscosity syndrome should be treated with urgent plasmapheresis to bring the viscosity of their serum down. This is considered a medical emergency, and it's always important to remember to never transfuse a patient who is hyperviscous, even if they are anemic. Thank you for listening to the Lymphoid Disorders lecture for the Hematology and Oncology unit of the General Medicine course. Please be sure to have your study guide completed for the application session for this class. Thank you.